smoothly.
Go for it. I'll stop sharing.
Well, thank you so much for allowing me to speak today. And as you mentioned, I was involved in the video for this campaign. So I'm a blind person, and I'll give some information about how I got involved in the campaign, because I think it really highlights so much of what the campaign is about. I went to register for a GP, and I went to register online, as is fairly typical these days and actually quite encouraged. And I filled in the majority of the form. And then when I got to the end of the form, there was a requirement to sign with your signature. And this is absolutely fine, except the only option you had was to draw your signature in a box. And this actually isn't accessible with screen readers. So I was in a position where I couldn't actually register for this GP because I couldn't access um, all the aspects of the form. So I did call the GP and explain this, and that their response was essentially that it must be just me not knowing how to use my technology. I explained that's not the case. I explained about web content accessibility guidelines. I really talked them through all of this, and it just still came back to them saying, well, it must be down to you. And in the end, I ultimately decided not to register with that GP because I felt very much like they weren't taking me seriously at all, and they weren't taking accessibility seriously. And if they don't take it seriously at something as basic as the registration stage, will they take it seriously when it comes to things like accessing my actual healthcare information? And I couldn't be sure that they would. So I ended up looking around and finding a GP which was further away, but that I could register with, who I've been with since. And actually, I wrote about these experiences online, and then Healthwatch reached out to me and said, you know, we're actually doing this research in this campaign, and would you like to be involved? And I said, absolutely, because I think it's really important um, to highlight issues around access and issues around why disabled people aren't connecting with our own healthcare, because it's a very, very significant problem. And I face this all the time as a blind person. So I very rarely receive information in a format I can access. For the most part, I receive communication through the post in print, and I've stated multiple times that, you know, I require this electronically. So my GP actually does communicate with me by text, which is great. But whenever it goes out to any other department, so the eye clinic, anything else that I see, I don't get communication in a format I can access. And obviously that's a massive violation of my privacy, because I'm faced with a couple of options, which is one, to try and scan these letters and access them using tech, which sometimes works and sometimes doesn't, or two, to ask someone to read them to me. And I'm not comfortable really sharing my healthcare information with anyone. I don't live with family, and even if I did, it's not, you know, I'm old enough that I'm not really comfortable sharing that with them. But I don't, to start with, so I don't have that option. And I often find that healthcare professionals, it's not that they don't want to communicate in an accessible way. I don't think it's us versus them. I think there are some people who don't recognize the severity of the situation, but I do think most people want to resolve it. It's just that they don't know how. So either they don't know how to flag it up on the system, or they don't know if it's even possible to. So I was told, I went to an appointment the other day and I said, well, I need this in another format that isn't print. And they said, well, that's just not possible. So it's this kind of education issue, I think, a lot of the time, or a failing of the IT system. You know, I don't know which one it is, but I do think that that needs to be resolved, because obviously as a user of the National Health Service, I'm kind of in a position where I want to be able to access my healthcare. It's really important that I can. It's very important that I'm able to educate myself, and that I'm able to take control of my own health. And I think we really encourage that, you know, in terms of public health, we encourage engagement from the individual, which is completely correct. But if you can't access that information, you can't actually engage with your own healthcare. And that is such a problem for disabled people. And it's not just a problem for blind people. You know, I speak about this as a blind person, but you have problems where deaf people are told, well, the only way you can do this is by making a phone call. Or deaf blind people are told the same. And, you know, for deaf blind people, it's even more critical, because I can pick up the phone. It's not something I would choose to do. I have ADHD, and I find that I'm not great at phone calls, but I could do if I had to. But for deafblind people, that may not be an option at all. So it's this thing of it's absolutely so vital. And I think a lot of the time people think it would be nice for us to have things in a format that we can access, but they don't see it as quite as important as everyone else. But imagine if you just never received your letters. I mean, that would be terrible. And that's basically what's happening to us as disabled people. And we have the problem that the complaints procedures either are just ineffectual, or they just take so much out of us, or we don't know how to complain. So there's all these kinds of things that come together and make it just so incredibly difficult as someone who wants to access my healthcare and who takes it very seriously. But it makes it very difficult for me to do so. I kind of don't want to talk too much because I know that there's some really interesting information that's going to come from the study that was done, and some really quite incredible statistics which didn't surprise me, but I think will surprise other people. And I kind of want to allow that to go ahead, and maybe we'll be here for questions if you have questions from like an end user perspective towards the end as well.
Fantastic. Thank you, Connor. That's absolutely wonderful. Thanks for everything you've done to support the campaign. As Connor said, we will make questions available at the end of the presentation. We'll move on to Urti now with her presentation. Urti's going to give a quick introduction to the campaign generally.
Yeah. So I'm just waiting for my slides to load up.
I can see a few comments in the chat about Zoom. We will explain regarding that
yeah,
when we get a chance
Holly's
later on.
responding.
I can see those slides, Urti, so hopefully everybody else can.
Okay, that's great. So just to give a bit of background, hi everyone. My name is Urta, and I'm speaking here on behalf of Healthwatch England and the campaign to give a bit of background on why we're launching this campaign now. So as I'm sure you all, of course, know, and I don't need to tell you, the Accessible Information Standard came into force in 2016, and it places a legal requirement on health and social care providers to ensure people are given information about their health and care in accessible ways. And since the COVID-19 pandemic began, we've heard from many more people who haven't had the support they needed to communicate with the health service. So we've seen a spike in feedback coming through from local Healthwatch about this being a problem. And at the same time, the issue is very much in the national media. So I'm sure people saw that Downing Street were taken to the High Court over their national COVID-19 briefings and not having BSL interpreting support in those briefings. We also know that the NHS is currently reviewing the Accessible Information Standard, and Malcolm will talk to us about that a bit later today. But we believe now is the right time to influence the standard and also band together to make some noise about ensuring that services are meeting people's rights to accessible information and communication support. Sorry, slides. Yep, here we go. So our vision with this campaign, we have several objectives. One is to raise awareness about why accessible health information is important to ensuring people get the care that they need. We've done some research to set out how the current system is not meeting people's needs and provide some recommendations. By launching the campaign, we want to bring together a number of organisations working in partnership who are committed to making change happen. And going forward, we will be running this campaign over a longer period of time, so there will still be room to engage additional groups disadvantaged by inaccessible information to understand their experiences and ideas to evolve the campaign and make things better. So we very much see this as a coalition. We're working with a number of organisations which have helped us to develop the recommendations as part of this campaign, which are listed on screen. but we invite anyone to get involved with the campaign and sign up and join as a partner, or indeed, even if you don't want to join, to reach out to us and meet with us. Like I said, we see this as an ongoing thing. We will still be publishing additional bits of work and events going forward. So it's very much not a done deal. Just setting out some background of our evidence and why it was raised to us by Local Health Watch that this is a real issue. So we reviewed the stories that over 6,200 people shared with us between April 2019 and September 2021 to look at how well the NHS is delivering the accessible information standard. And it won't be any surprise to people to know that while we had some examples of good communication support from services, we also heard from many people who aren't getting the right support. And just some of the key themes that came out of that research. So we heard from people whose needs were overlooked. For example, we heard from a blind person being given forms to order a white cane, or people with hearing loss who are expected to book appointments over the phone. The right support was often not in place for people. Even sometimes when they asked for it. So we had some examples of GPs refusing people access to interpreters. There was an inconsistent level of service. So sometimes even when people knew that the services had recorded their needs and they had had support in the past, it wasn't always picked up when they were booking a new appointment. We heard a lot about the burden that's placed on patients and families. So people often being forced to rely on friends, carers or families to support them in accessing healthcare, which made them feel less independent and disempowered. And as Connor is mentioning, often forced them to share sensitive health information when they weren't choosing to. We heard people saying that there was often a lack of awareness among staff in day-to-day interactions, and remembering that accessible communication is not just about alternative formats for printed or written or spoken materials, but it's also holistically about the way that services and staff communicate with people. And some people told us that they weren't certain about their rights under the standard or where to go for information. So that's just to set the scene, and I'm going to stop there. I'm going to come back and speak a bit more about our recommendations. But I think Mike from RNID is going to come in next to also give a bit more context on the scale of the problem from the work that they've done.
Hi, yeah, thank you very much, Urta. So my name is Mike Wordingham, and I'm a policy officer at RNIB, and I've been working with Sign Health and various other charities. We put out a survey at the end of 2021 for patients and healthcare providers about their experience of the AAS, and I'd just like to talk you through a few of the findings that we got from people who took part in the survey, and they very much chime with everything that Urta just said, and particularly with everything that Connor mentioned. So the first sort of headline is only 11% of patients covered by the standard have equitable access to the NHS. And that is a number that we developed by a method of scoring individuals as to the answers that they gave to 3 questions. If an individual's normal method of contacting their GP was one of their preferred methods, they were given 4. And if it wasn't, they were given 0. If an individual needed comm support, they were given a score from 1 to 5 based on the frequency of the support, and provided corresponding to 5 levels of frequency. And same approach for those needing alternative formats. And if an individual indicated need for both, these scores were averaged out. So it's a 1 to 5, and unfortunately there were so few people who that actually scored highly on this. Only 11% we considered to have equitable access. 77, sorry, I'm really sorry. I need to go to here. So 67% of deaf people reported that no accessible method of contacting their GP had been made available. So this again is something that Connor touched on. This is primarily due to providers relying on phones systems to book appointments. This is inaccessible when the patients cannot properly hear the person on the other end of the line, or may not be able to express their needs verbally. This is compounded with issues in communicating with receptionists, especially when wearing masks, added up to a failure to provide access otherwise afforded to hearing patients. And then 81% of people with communication needs have had an appointment where their needs were not met. So significant numbers of deaf and hard of hearing people having over the phone appointments scheduled for them, which were not accessible, providers refusing to book qualified BSL interpreters, I think that has been mentioned already, not being able to lip read since staff did not wear clear masks, and several mentions of professionals being impatient with them, not hearing the names at reception. And one of the people that I spoke to as part of getting case studies for our report that we wrote following the survey is deaf-blind, again, as Connor mentioned, as extra communication needs, and they said they hadn't seen their GP for since 2015, because when they've been to their GP, the experience has been so difficult. They've been left waiting in a waiting room where somebody would call out their name, but they wouldn't know where it's coming from, or there's a light system where they just didn't know what they were able to do. And the whole experience was just so difficult that they just had not engaged their GP for close to 7 years. So that's the kind of problems that people are experiencing. 77% of people with accessible information needs reported rarely or never receiving information in alternative formats. 77%. Blind and partially sighted patients often report that they are being provided with consent forms in inaccessible formats. Consent from a patient must be informed, which is impossible if their communication support needs are not being met. Another gentleman I spoke to, this happened to him. He went into hospital and for a procedure, and he was presented with a consent form that he couldn't access at all, couldn't read. His support worker who took him there had left, and they weren't able to come back. So he'd been waiting for this procedure for a long time, and he was in pain. But he was sent home and wasn't able to have the procedure at that time. And someone else I spoke to as part of the report said the chronic pain clinic refused to send me email letters and told me they didn't have time to comply with the AAS. I asked how they expected me to read a printed letter, but they weren't interested. I did not know they had sent me appointments, as I can't read the letters. Eventually, I received a phone call saying I was being discharged from the clinic for missing appointments that I didn't even know I had. I reiterated that I needed email communications, not letters, but again, they just didn't seem to care. It is extraordinarily frustrating. So someone who was discharged from a chronic pain clinic because they were receiving things in a form they couldn't read. Another person said, I literally begged my GP to send me my smear test results in Braille. It did not happen. It happened that my father-in-law saw the paper and read it, and it was so humiliating. No woman should experience this. My medical results are my private affair. Again, this is something that Connor spoke about earlier. Also, Moorfields are still sending me all communications in print, although they both my eyes. I begged, requested, complained, nothing. So people come to us frequently saying they're put in positions which are humiliating. Someone else came to me when I was collecting case studies for the report, and like Connor, they had their test results came to them in a format they couldn't read, including pictures from ultrasounds and X-rays, and somebody from social services would come around to read their letters, and they had to give them some really intimate medical test results, and they'd never met this person before. So it really puts people in a humiliating and difficult position. We touched on this already, but again, only 41% of complaint procedures were reported to be accessible. So we've already had the problem of not being able to receive our information in a format that we could access. We weren't able to manage our conditions, and then when we try and complain about it, 41% of the complaint procedures aren't even accessible, so we don't know what to do. Again, this has been touched on, and by this point, the barriers that are being put up for us being able to just access the same care as everyone else, it's just makes it extremely difficult. 31% of professionals reported that their services never provided training on the AAS. 37% of healthcare professionals said that their healthcare practice never provided training. So many blind and partially sighted people come to us at the RNIB, and they have asked for things in their preferred format. They've asked people to email things, and they just get presented with blank stares from the people there, or being said, "Oh, can't you get someone to read it to you?" All these things which are incredibly difficult to hear and frustrating, and because the frontline staff who are dealing with them have no idea what the accessible information standard is. So it's really important that training is mandatory and is about the AAS, and that people know what rights their patients have. There are some best practice examples in this report. So some people have told us, for example, that one person said, local orthotics hospital have provided BSL interpreters for all my hydrotherapy appointments without fail. This has enabled me to access hydro where I can't use my hearing aid and hear nothing without it. I'm really profoundly deaf in most frequencies. The booking system they have for interpreters just works. Reception staff tick a box when appointments are booked or added later, and the booking goes through the Common Plus and local agency. And then another lady who I spoke to, who is completely blind, said, oh no, sorry, this is a deaf-blind lady I spoke to, and said, I had the most fantastic experience. I sent an email to audiology, and I sent it in a very large format and in bold, because I cannot see it unless it's really bold. I got a reply in the same format that I sent my request. I was overjoyed because I had the most amazing email conversation with the person who was trying to arrange the appointment with me. When I spoke to that lady, she clearly was overjoyed, and just the ability to communicate with the people who are managing her health condition was something that, she was so excited, and it meant that if we don't get that kind of service as people with communication needs, and if we can't communicate with our healthcare providers, we can't control, we can't manage our conditions, and this leads to so many difficult situations. And if we can't manage our conditions, we can't keep, COVID has taught us anything. If we can't manage our conditions and get things in our preferred format, we can't keep ourselves or our community safe. And one last point I'd like to make is that over COVID, so many things have moved online, as we know, whether it's GP's appointments, or how to contact your GP or get your medication, whatever it is, or attend anywhere. And this works really well for some people. And Connor was talking earlier on about text messages. And for myself, I'm registered blind, and getting things on text message or doing things over attend anywhere works really well. But there is a digital divide in this country, and sight loss in particular is very dependent on age. So older people are much more likely to not use the internet. And 63% of people with sight loss age 75 plus, 60% of people with sight loss age 75 do not use or have not access to the internet. That's compared to 52% of the same age group. So when 63% of people over 75, that's some really important cohort of patients who don't have access to the internet or smartphones. So any solution to the AIS has to be a mix of both technology and making sure that we reach out to people who are digitally excluded. So that is my presentation. So thank you very much.
Thank you so much for that, Mike. I think Deborah's comment is a really good one. She said it's good that you've got best practice examples as well as the negative ones, but it's very sad that those best practice examples was just people getting what they should get, what everybody else who's not got any impairments gets in the first place, but they were overjoyed just to get that equitable access. So it's bittersweet in a way, I suppose, isn't it? Thank you. I think Urta's going to come back in for a few minutes now. And just a general reminder to everyone speaking, if we could just keep our speech slowed a little bit, that would help some people following the conversation.
Sorry, that's not the right screen that's being showed. I don't know why that's...
Sorry, I was just trying to keep us to schedule.
No, that's great. It's just not allowing me to share my presentation.
Can I help? No, I think it's coming up now, Urta.
It should be the slides rather than...
There's another interesting comment in the chat while we're waiting. I can't see this person's name, but they're highlighting how just one good manager can improve accessibility, but a poor one can make it a nightmare. And it often comes down to attitude. There's a little bit more
sorry,
detail.
Chris.
Sorry.
Could you move on to the next speaker, because I'm having difficulties, and I'll summarize at the end.
Okay, no problem at all. So our next speaker is Christina Kozlowska from, I hope I've got your name right, Christina, from Leeds Teaching Hospitals.
Indeed.
Thank you. Christina's trust was one of the trusts across England that we recently submitted FOI requests to try and measure their compliance against the Accessible Information Standard. Leeds Teaching, by their own admission, are not fully implementing the standard as they would like to, but they've been very open about this, and Christina's with us because her local Health Watch, Leeds, recommended them as a trust that are really doing their best and doing everything they can to improve the experience for patients covered by the Accessible Information Standard. And Christina's going to talk about some of the measures that they're putting in place to do that. Thanks, Christina.
Thanks ever so much, Chris. I'm joined today, everybody, by my colleague, John White, who is the lead nurse for patient experience, and he'll also be talking through some of the things we're doing as a trust to support improving experience. I'm just going to share my slide now, if you just bear with me a moment. Hopefully, you can just help me understand if you can see that.
Yes, that's come through, Christina.
Brilliant, thanks so much. Let me just see if I could increase. Is that better watching it that way, Chris?
Yes, much better, thank you.
Okay, lovely, everybody. So I can't see you now, so please just shout up if there's anything you'd like to interject with. So Leeds Teaching Hospitals is a huge organisation. I just wanted to say that first to give a sense of the scale of the work that is required to enable AIS standards to be delivered universally across our trust. So, for instance, we treat 1.5 million patients every year, and have 20,000 staff. So I notice in the conversation so far we've been talking about training. Of course, that's imperative to getting this right, and hopefully you can see when you're dealing with that number of staff how tricky it is and how challenging it is for that to be consistently delivered, for instance. So there are challenges with delivering the AIS, and I thought it was worth saying that, and this is not to discredit in any way the importance of the AIS. We know it is vitally important, but genuinely, if it was easy to deliver, we would already have done it. And the fact is that from a big hospital perspective, it is very, very hard to get it right. So not an excuse, but I'm just going to talk through some of the challenges that we have as an organisation. So one of the challenges is enabling our internal IT systems to talk to each other. So in order for all our clinicians to have access to patient information and the flags that actually indicate what communication needs they have, our systems need to share that information between themselves. We have over 200 clinical systems in place in our trust, for instance, and again, the scale of that hopefully is evident in terms of the difficulties that come with that. One of the key things you've talked about today so far is GPs, and as an organisation, one of the key challenges for us, and one of the things that our patients tell us, and kind of is echoed by what I've heard today, is that you know, what we really need to see as an organisation, when we first receive a referral from a GP, is information in that referral that helps us understand what the communication need of the patient would be before we even ever see that patient. And a lot of our concerns and complaints that are raised relate to, you know, a disbelief really that we couldn't possibly understand, we couldn't possibly know that a disbelief from patients about how we don't know that they have a communication need, and it's simply because the systems that are used in GP, the world of GPs, don't talk to the hospital systems, and it isn't the hospital just itself that needs to fix that problem. It is a global citywide system change that needs to happen to make that occur. We've talked today about the outputs of what need to happen once a communication need is identified. So for instance, delivering large print consistently or braille consistently. And again, the software requirements associated with that might not be available consistently across all our systems. There are information governance concerns associated with these processes. So you've talked today really sensibly, really understandably about the need to have email access, not to have phone systems as our main route of communication. When we start to move into using email and those kind of processes, then there becomes a requirement to capture information about people's consent for sharing information electronically. So there are obstacles there. Funding is an obstacle because actually making these changes within the organisation costs money. It requires analyst time, developer time, money to fund all that, and probably bits of digital kit that I don't even understand to put together to make that happen. Because we've got so many staff, as I've said already, it involves a huge number of people in making a change, and as also has kind of already been alluded to, lots of different people are responsible for separate pieces associated with getting AIS right. So obviously clinical staff are involved, digital staff are involved, we've got experts in patient information, etc., etc. And it's about bringing all those together and having a cohesive approach actually that's going to get this right for people. So we are tackling this as an organisation. We're really proud about this. I've heard today about the need for a strong manager. I would absolutely 100% concur with that. About 18 months ago, we set up an AIS steering group in the organisation. Now, we absolutely understood that it needed to be a senior person in the organisation overseeing this work. So we have an associate director leading that group. We've got another group that steering group reports to, which is chaired by the deputy chief nurse of the organisation. And a piece of work has been commissioned, actually. So we have undertaken a service analysis in our audiology department, and the purpose of that was to really follow a patient journey through our service and to understand what was wrong with it. You know, where did we go wrong? Where were we failing to meet the experience of the individual in the way that absolutely we should have done? And from that, we really started to understand actually what we needed to fix, starting with looking at that from a digital perspective. Following that, we have commissioned a digital business analysis, and we are currently working on that being achieved. So what that means is, as a trust, we are trying to understand what bits of IT digital kit have got to start to work together to enable our systems to operate in the way they need to support patient care, and how much time that's going to take, what resources we're going to need to do that, and crucially how much it's going to cost. So that is happening at this moment in time. Now, I am not going to sit here and say that that's going to be a quick piece of work and that we'll get to an end of it as quickly as we would like to. But what we're not doing is relying on our laurels. So I absolutely know it's not okay to wait. The senior people in this organisation know it's not okay to wait. There are still lots of things we can do to improve experience. And actually, in my view, all those other things we're doing now form part of that jigsaw to getting this right going forward. So I'm just going to go on to talk a little bit about some of those things we're doing now. One of the things we're doing, and this might actually help answer some of the concerns that have already been raised so far, we're taking forward something called a patient hub. So for us too, we get lots of our outpatient queries relating to patients feeling that the way we communicate with them isn't accessible. So the work that we're doing around a patient hub will enable patients to interact through an online portal, and they'll be able to accept, cancel or rebook their appointments without the need to call a booking service. So for us, this is a big way forward from the way we've traditionally done it, and I think from what I'm hearing from the way other people have experienced too. It'll absolutely be patient choice whether to receive this service, and those who wish to will still be able to receive a physical letter. We're starting that in our organisation now, and there'll be a phase-in of that across the rest of our specialities, with us learning along the way what we need to do to make it successful. The second piece we're doing currently is looking at our administration system. That's called PAS. We've been spending the last year upgrading that system, but what we now have, which we didn't have before, is the functionality to capture consent from patients to be able to share information via email and text. So you'll remember I spoke about that. And over the next year, we'll be implementing that in this trust too. So you see little bits of the jigsaw kind of coming together to build the overall experience, hopefully, of improvement. I've also heard today about digital exclusion. I'm taking forward a digital flag in this organisation. So what I want to see is where people don't have access to a phone or don't routinely use have access to a PC, for instance, that we flag that within their care record as well. And it just enables clinicians, I think, then to have the right access to the right information to plan care in the right way for individuals. And I'd quite like to see a carers flag introduced as well, actually, so that we signal when somebody has a carer up front. Again, to support the conversation where it's needed to involve that carers aspect. I've recently been successful at taking forward a bid for £67,000 to achieve visual access guides on all our hospital websites. So this is about visually enabling access and providing information in an accessible format, because we get lots of queries from people and lots of concerns raised where individuals consider they can't physically access our hospital sites in a way that makes sense to them, and often it's the most vulnerable of our patients that find themselves in that situation. So something else we've done. We're very fortunate here, and I think one of the groups of patients that are looked after very well are the learning disability and autism patients who have those conditions and difficulties. And the LD and autism team support patients to have a passport. All those patients are flagged as we understand and care for them in the organisation and identify that they are with us. They are flagged and they are supported then by the LD and autism team. But because there is that close connection and the team are alerted every time a patient from one of those groups is admitted into the organisation, they get very good support and with access for their communication needs. We also work with a third sector organisation called Carers Leeds, and they provide support for carers, so we can refer carers to them directly for support. And again, they are incredibly instrumental in helping people navigate the hospital systems. I know I haven't got long, but I am going to pass you briefly over to John now to finish the rest of this presentation. We've got a couple of slides, but he's going to tell you quite practically about some of the things we do around interpreting patient information leaflets and such, which again I've heard about today.
Thank you, Christina, and thank you everybody for listening. I did, just in relation to the learning disabilities and autism team, I have put a link in the chat about the team and the link to the passport in our hospital. So please take time to look at that. I guess alongside that, I want to tell you a little bit about our patient information forum, which has developed the Leeds Hospital web pages to host over 1,000 patient information leaflets, and in conjunction with the learning disabilities and autism team, we've got 27 easy read leaflets on the website, and as of last week I know there are about another 70, that's 70 leaflets in production. I know the team are working extremely hard. They've recruited and got people in post to really address this, really important. We're using assistive website technology for all, and so all leaflets and information on the website can be translated into multiple languages. It allows for the text to be spoken out loud with read along, highlighting the areas that are being read. It's got a text magnifier which reads out loud the text. I've also got an MP3 maker which converts the online content into MP3 files for easy listening, and I have got if we have a little bit of time I can demonstrate this if we wish to. I've got the web link up to showcase that if we need to. Next slide, thank you. We've also got instant access to interpreting for many different languages via our video interpreting machines, and also including for video consultations as well. This is a really important feature, particularly during COVID, where all ward iPads, so nurses and doctors can access an interpreter instantaneously on an app. So if somebody does require translation into, say, Polish, for instance, it can be done there and then with the patient and the nurse at the bedside. So it's a fantastic feature. We managed to push this out to every single ward, every single iPad, to allow this to happen. And following feedback from our deaf patients and also organisations who represent the deaf community, we've established a deaf and hard of hearing action group, which is relatively new. But what we have done is to set out 6 commitments that with associated work streams that we are working through at the moment. And these are really important commitments that we want to make to individuals who use our services. And again, I'm happy to share those with you if you wish as well. And so we are really keen to progress the work streams. And I know I was listening to Connor earlier on about access to things like the complaints information. And I guess what we're trying to do is to make sure that we actually do listen to what people are saying, but also work with people to achieve what we need to achieve to make things accessible for everybody. So we're really extremely keen to do that. Going back to we've created interpreting sessions for social interaction in BSL, and this was in a bid to reduce isolation during COVID when visitors were not allowed to visit patients, and they're still not in the majority of situations. So our team managed to supply iPods to every ward in the trust with the video app Just Talk installed on the iPod. And we facilitated a BSL befriending service with our supplier of BSL, the Leeds Society for Deaf and Blind People, and this was extremely well received by patients and staff and relatives, and valued by all of those who use the service. So we're really proud to be able to do that, and it was something we managed to arrange incredibly quickly as well. We're also looking at our training resources, and heard earlier on about training, about making training mandatory for staff, which is what we are extremely keen to do that, particularly around the BSL awareness. And we are working with the National Deaf Children's Society amongst organisations to help with that as well.
John,
so
I'm very sorry
I've
to interrupt.
through, and I've come to the end.
We come to the end anyway.
So thank you very much for listening. That is the end of our presentation. If there are any questions at a timely point, then obviously Christina and I will be very happy to take those. Thank you.
Fantastic. Thanks to you both. That's really, really helpful. We'll bring in our next speaker now if I can. Malcolm, see if he's popping up. So Malcolm's currently working for NHS England on the review of the Accessible Information Standard. And Malcolm was previously led the rapid review on British Sign Language on behalf of NHS England and Improvement. So if Malcolm's with us, thank you.
Thank you for inviting me today. I'm joined by a number of my colleagues from NHS England, in particular Michael Brady, who's leading this work, and a number of our project teams. I'd like, Stacey, could you just start to show the slides for me, please?
Yeah, can you see them?
I think they're probably on their way up. Okay, let's put it. Okay, so first of all, thank you very much again for inviting me along today. A large number of the areas that you've been highlighting are very, very similar to the concerns that have been raised throughout the work that we've done, both on British Sign Language, but also on the Accessible Information Standard. But we're also delighted to say that we've identified places like Leeds as areas of really good practice. And even though my presentation today is primarily about the AIS, I've been rather cheeky with Urta, and I've asked if I could just have just maybe 1 minute to talk about the work that we've completed on British Sign Language. So the review was published last spring, and it's contained on the NHS Futures website, and at the bottom there's a link. We were asked to undertake a rapid review of British Sign Language at the time of COVID, of course. We came up with a detailed report, and a detailed report is also available, the highlights using BSL, and it's on the NHS Futures website. From the findings, we were able to draw out a series of recommendations, and all of the 17 recommendations have been accepted by NHS England, and they broadly fit into 3 areas. The first one is the integrated care systems, the new integrated care systems, which will become live from July of this year, really having a strong role in coordinating the commissioning and the quality of British Sign Language provision across the communities. And what we've heard today is how important it is to have really good and really strong commissioners. We viewed that the ICS, the integrated care systems, would be a really good place for them to have a significant role, but their role would be involved in making sure it was much clearer to make complaints, make it much more clear there's one place to go and get advice, and also one place to really support the delivery and the integration and the strengthening of local charities to provide BSL services. 111 also provided a really strong support throughout that whole period of COVID. What we realised is that we really needed to do much more. So we're working with NHS 111, working with representatives from charities to design and to develop a new service to actually enhance the current offering for 111. And Michael and myself and the team will want to put out more information this spring about the timescales for doing that. So the areas of concern about 111 we've heard, and we're working on those, and we're building on the good work that Sign Health did throughout the whole of the period of the pandemic. So a big thank you to James Watson O'Neill and his colleagues on that. The quality and the education is really variable for BSL, and it's an area that we really know that we've got to work with the commissioners and the providers to make sure that there is huge greater awareness of BSL and the fact that people have got a legal right to have an interpreter, and it's not the responsibility of the patient to identify an interpreter, but the interpreter should be there. And in the chat I saw earlier about the word about choice, something that really underpins our thinking with British Sign Language, that there should be choice available. People shouldn't be shoehorned into having digital solutions where there is a stronger preference for it to be done with face-to-face. So again, the work that we've done really has identified and listened to what service users have actually said to us, and that's really driven the 17 recommendations. So for those of you that are interested, the report is hosted on the NHS Futures website, and that includes the recommendations. And the key thing that I think that's come through in the conversation so far today on the AIS is that the real work has to be on the implementation. People aren't questioning so much the standard, but they're questioning the rigor and the effort to have a strong implementation program. So that's what Michael and myself are really focusing on, building on the work that's been done so far by Urta and her colleagues, the work that's been done with Sign Health, and actually learning from that, but working with service users. So the next slide, please, Stacey. So the next slide really coming into the AIS. What we did here, of course, with the work with BSL, was that people didn't really understand the legal responsibilities that they had, and there should be a interpreter provided at appointments. And the process of working with charities and working with service users has been reflected in our approach for the AIS. So what we're doing for the period now until the end of March, but it will have to be a continuous consultation program with charities, is to undertake a review that doesn't just look at British Sign Language, but looks at mental health, and it looks at all of the other areas that occasionally gets overlooked when people are talking about the AIS. So in terms of the data, we're going to build on the data that's been provided that Urta and the team have actually undertaken. And what we want to do is to take the set of findings and recommendations back to the NHS England policy teams and back to the legal teams. And we will then work on shaping a strong implementation programme, very similar to what we've actually done with British Sign Language. The next slide, please, Stacey. A little bit of a boring slide, this, I'm afraid. It's really just to show you the governance that we're working with. So we have an overall programme board that is chaired by Michael Brady, that has increasingly service user representatives, members from the AIS coalition groups, and strengthening increasingly the role of people from social services and local government sitting on that group. A lot of people are saying to us from local government that we're talking to is that they see the AIS is very much around about the NHS, and of course we all know that it isn't. Specifically the AIS reference group is where Michael and his team are talking to the various policy leads. We want to make sure that when policy is being developed across Department of Health and Social Care, NHS England, that they're really thinking about AIS the whole time when they're developing policy. When there are policy announcements, there should be versions that are available in easy read and also in British Sign Language. We decided to do the coalition group and the review built on the structure that was done on the 2017 review that was carried out on AIS. So we've designed 4 groups: learning disability and autism, the sensory, the mental health group, and there was a group that we inherited with the title of other communication needs. And that's where we're working with charities representing Huntington's and aphasia, etc., to make sure that those groups are fully identified and recognised inside the review, and the findings support all groups. So the deliverables are on the right-hand side, which is a review of the Accessible Information Standard, and then a series of recommendations to be considered by NHS England. We'll provide updates on the programme on the NHS Futures website, and we'll continue to work with all of the charities and continue to work with the coalition groups themselves. Stacey, could you just move to the last one? So the process, we've undertaken a large literature review. We're working with Urto and their colleagues on what are the findings from the review here, and we're going to use that in a lot of our baseline findings. We're undertaking an enormous number of meetings with stakeholders, with charities, and with service users, and we'll be setting out the first tranche of our findings by the end of this month, and some very, very high level recommendations for NHS England to consider. And I stress they're going to be high level because I think we need to do more work on making sure that the recommendations are fully inclusive and they address the needs of all of the 4 AIS coalition groups. The number of workshops that have been undertaken so far is 38, but literally as I've written that, Rachel and myself have undertaken several more since we've actually drafted that. The work on the actual standard and the updating of that, I project we'll be starting to do that from June of 2022. So there will need to be much further consultation across all of the policy teams, across stakeholders and charity groups, and really developing a coalition with groups like yourselves throughout the whole of the summer period to make sure that the updated AIS meets the needs of patients, commissioners and providers, and it's really fit for purpose going forward. So Michael and myself really understand the enormity of the tasks that we're undertaking here and why it's absolutely vital to get right. We really need to make sure that the consultation is thorough, and we really need to understand what the real challenges are that are facing. Christina's really helpful feedback on digital and clinical information system is of course one of those, but one of the early things that we're really finding, of course, is the lack of awareness that we've got of health and social care staff on the rights that patients and the public have got and how we need to address that in the short term. So again, Urta, thank you very much for the invitation to join today, and I hope it's a conversation that we can continue to have over the summer period.
Thank you, Michael. It's really helpful. I can see there's at least one hand up, but Urta is going to come in quickly, give a quick overview of our recommendations before we go to a discussion. Urta, we can't hear you if you're.
Hello, this is Nick Fowler. Can you hear me?
I can, Dick. We were just going to go to questions in a few seconds, if that's okay.
Yeah, I just want to know, where is chat on the screen? I can't find it.
So towards the top right, if you're able to see a speech bubble emblem
No.
next to the participants icon.
No, not got it. No, if I need to say anything, I asked some questions in advance, but if I need to say anything, I'll just have to come on at microphone. I'll sign off so you can continue. Sorry.
I will come back to you in a few minutes, Dick. I'll make sure we do.
Thank you.
Thank you. I don't know if Erta's been able to
Okay,
rejoin
can you hear
us.
me?
I can, yeah. No,
And
no
can you see the
presentation
slides?
now. No.
Okay, I'm sorry about that. I'm having technical difficulties, so I'll just go ahead without sharing the presentation. So I just wanted to quickly round up. We've got a number of quite detailed policy recommendations for the campaign, which are on our website, but I'll just quickly outline the areas in which we're making recommendations, which I think align really well with the areas where we've got evidence, and the areas that Malcolm has just outlined and which Mike shared earlier. So first, we'll be campaigning for health and care services to be made accountable for fully delivering the standards. So although the AIS is a legal requirement, currently there is not much clarity on accountability in the system for delivering it. So we've got some clear recommendations around how CQC should take account of AIS compliance as an element of provider assessments and ICS assurance processes, and that providers really need to be asked to evidence compliance as part of assessments. And also that there needs to be clear expectations set for integrated care systems around accountability for this. So we're recommending that local boards appoint a member of the board responsible for ensuring that services meet communication needs of all their local citizens. Second, we're recommending that every health and care service should have an accessibility champion. So similar to the Freedom to Speak Up Guardians program around the country, where you have someone who gets additional training and is linked up to the ICS lead, helping to spot local challenges, barriers, and best practice. Third, we're really making some noise about the need for better IT systems so that patients can update services with their communication needs. So the vast majority of services that told us they are not able to implement the standard said that one of the main barriers were IT systems that just weren't fit for purpose, but they felt powerless against kind of wider commissioning arrangements or tendering processes to change that at service level often. Fourth is highlighting the importance of involving people with communication needs in designing better services. I'm sure we here all agree that people with lived experience, communication needs are absolutely central to informing and creating change. So we're talking about how integrated care systems should have lived experience panels representing people with information needs, and that these panels should be involved in reviewing existing services.
Sorry, Lorraine, interpreter here. Can I just ask you to reiterate that last point again, please?
Yes. Fourth was around involving people with communication needs in designing better services. So ensuring that integrated care systems have lived experience panels representing people with accessible information needs, and involving them in reviewing existing services and monitoring the accessible information standard. And finally, really making the point about the importance of training for health and care staff, which is currently part of the standard, but we know it's not being delivered everywhere and it's not mandatory for all staff. So as I said, the campaign is going to be running really for us over the next year. In the first phase, we have launched our various bits of research that we've done and our policy recommendations and the issues that we've already found with public feedback. And later on in March, we'll also be launching some additional research that we've done with people who don't speak English. And we're also running a survey collecting additional experiences from people with other groups, outside of sensory impairments and disabilities that we haven't had as much of a chance to reach out to in the first phase of the campaign to understand their experiences. And later on, we'll be publishing some additional findings and recommendations to do with those groups. So sorry, the slides are not showing on this, but some of the ways you can support the campaign is to help us create some buzz on your social media channels and get your networks involved. So we have a full comms toolkit available on our website with, social media graphics, key messages, bullet points, all sorts of things you can use to share our findings and recommendations, and also to make your own calls to action. You can sign up to be an official partner of the campaign. And get involved with the coalition. So just email me to do that, and I will put my email in the chat again. Please also just feel free to get in touch to share your thoughts, and we're happy to set up any follow-up meetings on how we can develop the campaign going forward. You can share our survey so that more people can tell us about their experiences, and we can use this feedback to develop further recommendations and phases of the campaign. And we'll also be feeding that directly into NHS England's review of the standard and the work of Malcolm's team. So thank you very much for that, and apologies for the technical difficulties, but we do have about 20 minutes left now for questions and contributions, which